Yeah, my name is Liz Van Dril. I'm a clinical associate professor at UIC Retzky College of Pharmacy. And I'm also our residency program director for our PGY2 ambulatory care residency, as well as a clinical pharmacist in our internal medicine clinic.
Hi, my name is Lauren Cunningham. I'm a clinical pharmacist and a clinical assistant professor at the University of Illinois Chicago Retzky College of Pharmacy, and I am also the assistant residency program director for our PGY2 ambulatory care pharmacy residency.
Yes, thank you for the question. Despite clear recommendations for screening for both diabetes and kidney disease guidelines, early identification of chronic kidney disease or CKD remains one of the biggest opportunities for improvement. Many people with diabetes still don't receive those components of recommended CKD screening, so an estimated glomerular filtration rate or eGFR to assess kidney function, and a urine albumin to creatinine ratio or UACR to assess kidney damage. And that matters because CKD is often asymptomatic early on, much like a lot of our other chronic disease states. Someone can feel completely well while kidney damage is progressing, and many people don't learn that they have kidney disease until it's more advanced. The screening recommendations for people with diabetes are pretty straightforward. For people with type 1 diabetes, annual CKD screening should begin 5 years after diagnosis. And for people with type 2 diabetes, screening should begin at diagnosis and continue annually. And then both eGFR and UACR should be checked because either one alone can be abnormal and indicate CKD. And then another step that's often frequently missed is complete staging when patients are diagnosed. A lot of the times in our patients' notes, we see CKD being classified on the basis of eGFR alone, but again, the albuminuria component is missing. Both eGFR and albuminuria provide an important prognostic information, and together they help determine a patient's risk for both kidney disease progression and actually cardiovascular events too, which we know cardiovascular disease is the most often cause of death in people with CKD. So pharmacists would really encourage the use of full CKD classification system from the Kidney Disease Improving Global Outcomes or KDIGO guidelines. And that includes staging based on GFR, so stages G1 through G5, and then also albuminuria category, so A1 through A3. And a person can have completely preserved eGFR, but significant albuminuria, and still be at risk for kidney disease progression and cardiovascular complications. And we know pharmacists are really well positioned to standardize these processes across care. We can build reminders into diabetes management programs for screening, review laboratory data to identify patients that are meeting CKD criteria, and making sure that we get those albuminuria results appropriately confirmed when they are abnormal. We can also do a better job, documenting that CKD staging consistently and facilitating timely nephrology referral when appropriate. And then most importantly, we can always help close the gap between identifying CKD and acting on it. A CKD diagnosis should, lead to evidence-based treatment and not simply become another item on a patient's problem list.
Yeah, thank you for the question. The approach to diabetes-related kidney disease has shifted from a single drug strategy to a layered approach. Rather than asking which therapy to choose, the more useful question really becomes whether all appropriate foundational therapies are in place. Current evidence supports a framework that includes renin-angiotensin system blockade with an ACE inhibitor or angiotensin receptor blocker ARB, an SGLT2 inhibitor, and when appropriate, a GLP-1 receptor agonist and or a nonsteroidal MRA. These agents target different pathways involved in CKD progression, and the benefit of using them together can be greater than the benefit of any one therapy alone. In general, treatment starts with optimizing blood pressure and initiating or titrating an ACE or an ARB when indicated, particularly when albuminuria is present or eGFR is indicative of CKD. While ACE or ARBs are important for hypertension management in this population, albuminuria itself is also a key reason to consider them, even in people without hypertension, because of their kidney protective and albuminuria lowering effect. It's also important to remember that kidney outcome trials demonstrating benefit with ACE inhibitors and ARBs used maximally tolerated doses, not just those lowest doses of the agents. Pharmacists can really advocate for thoughtful titration towards evidence-based targets while monitoring serum creatinine and potassium. A modest reduction in eGFR following initiation or dose escalation of an ACE inhibitor or ARB is expected and does not necessarily indicate acute kidney injury. Historically, continuation of therapy was considered acceptable if serum creatinine increased by no more than 30% from baseline. And now current guidelines similarly support continuation when the decline in eGFR does not exceed 30% from baseline, recognizing this initial change as a predictable hemodynamic effect rather than evidence of actual kidney injury. When adding an SGLT2 inhibitor, it is also important to anticipate this initial decline in eGFR. This occurs because the medications reduce intraglomerular pressure through restoration of tubuloglomerular feedback. Since both ACE inhibitors or ARBs and SGLT2 inhibitors can cause this expected hemodynamic decline in eGFR shortly after initiation, many clinicians will actually prefer to stagger their initiation or dose increases for these agents. So one practical approach may be to initiate or optimize the ACE inhibitor or ARB first, repeat that lab monitoring in 2 to 4 weeks, and then add the SGLT2 inhibitor once we know that kidney function and potassium are stable. And the same principle applies to ACE and ARB dose escalations, initiation of an SGLT2, and then addition of something like finerenone. They do not all need to happen on the same day, right? Spacing these agents out makes it easier to interpret the lab changes, assess tolerability, and identify any causes of adverse effects if one does occur. So some clinicians might separate the initiation of a RAS inhibitor and an SGLT2 inhibitor by maybe 1 to 2 weeks, or maybe a little bit longer. It's also important to consider balance of kidney protection with immediate glycemic needs. SGLT2 inhibitors provide substantial kidney and cardiovascular benefit even at lower eGFRs, but their glucose lowering effects actually decline as eGFR falls and becomes quite limited when eGFR is 30 or below. So when someone has CKD but a very high A1C, it helps to consider the main clinical priority at that visit. So for example, if someone has severe hypoglycemia, obesity, and an A1C above goal, a GLP-1 receptor agonist may provide more immediate A1C reduction and weight loss, along with long-term kidney and cardiovascular benefits. That does not lessen the value of an SGLT2 inhibitor, it just simply reflects thoughtful sequencing. So we might want to start with the GLP-1 receptor in this case to address that immediate glycemic concern, and then make a plan to add an SGLT2 shortly after for the kidney and cardiovascular protection. So the goal is not really to choose one over the other, but to determine which intervention provides the most immediate benefit. And then nonsteroidal MRAs like finerenone are generally best viewed as another layer of protection for people with type 2 diabetes, persistent albuminuria, and acceptable potassium levels. Current KDIGO recommendations position nonsteroidal MRAs after foundational therapy, including RAS blockade and an SGLT2 inhibitor, if there was still some residual kidney risk remaining. And before starting this therapy, pharmacists can make sure that potassium and kidney function are stable and implement repeat monitoring approximately 4 weeks after any initiation or dose adjustments to confirm no hyperkalemia has developed. And the manufacturer prescribing information for finerenone has very clear-cut guidance on how to manage the potassium and eGFR levels with initiation and dose titrations while targeting that maximum dose of 20 milligrams per day for CKD. And then most recently, we have some evidence from the confidence trial that suggests simultaneous initiation of finerenone with an SGLT2 inhibitor produces greater reductions in albuminuria than either therapy alone, which really reinforces the value of combination therapy when appropriate.